Thank you very much for the introduction, Adrian, and thank you for joining the session. I fear I've been called an expert in the field. This is an area that I'm really interested in, and I've started reading more and more about how we can change our departments to have a more environmentally sustainable future in radiology. So I'm a learning person trying to be an expert, and I can share some of the things that I've learned over the last 6 or 9 months when I've really started to delve into this. So if we look ahead and we think, how do we want to shape our departments, really even towards 2030, we need to work on this relatively quickly. We know that in our area, our domain, we have very rapid technological advances. Now we're looking towards integration with wider diagnostics, hospital systems and research activities, and we know this. But I think when we look forward, we're going to have more societal-based important areas that our departments are going to have to really look at, address, and be mindful of. Patient-centered care and communications, I believe, are going to be more important. We have a big job in workforce development in radiology as we look forward. But today what we're going to talk about is what is radiology's environmental impact and how can we really bear down on the carbon that we produce without impacting on patient care. So green radiology, what does this look like? What does it mean? Sustainable healthcare, I looked up what is the definition of sustainable healthcare, and I found that the Royal College of Physicians gave this particular definition. This is the capacity of a health service to deliver healthcare over time with a consideration to future generations. So it's a broad definition that allows us a vision. What are we trying to achieve? We need also financial sustainability, but we need societal and environmental sustainability. Healthcare generates approximately 10% of the United States greenhouse gases. At the moment, our departments, we currently prioritize patient safety, cost savings, convenience, turnaround times, rather than sustainability. So how can we reduce our carbon footprint whilst maintaining patient care? Can we reduce energy waste in radiology? I think we need several partners. Industry need to help us with the development of sleep modes, standby and power save modes. We need to look at heat waste recovery systems, and we need potentially better systems for the circular life of our equipment, such as refurbishment of old scanners, upgrading rather than new builds. We probably do need government support behind this. EU or governmental directives may mandate energy savings in healthcare, potentially by working with industry, for example, having an energy saving system like we have on our washing machines or hair dryers. You know, what is the energy rating for a particular device? And there is potentially a group that can help with this, the European Coordination Committee of the Radiological, Electromedical and Healthcare IT industry. So there may be routes that we can look at to try and lobby for change. But we need to look to ourselves in our own department. We need to ensure smooth and efficient workflows to reduce on-time but not in use time. The departments of the future need to monitor energy consumption. We need to plan the layout of scanners and departments, reporting rooms to share cooling systems. And I envisage an energy dashboard. But that's a dream. I mean, these are big ideas. How do we achieve this? I think we have to start by measuring what our baseline carbon output is. And this can be done using mathematical modeling to look at the impact of our carbon output before and after a particular intervention, like reducing the wait time to sleep for monitors. But in the end, modeling is no substitute for actual data collection. And there's a risk that data collection is not being undertaken at the moment in our departments. We have big challenges because life cycle assessment of carbon is highly complex and very difficult. And it's almost impossible to imagine how we can get to that point. But we need to step up to this challenge to avoid the potential greenwashing by simply using modeling. So I was very impressed when I went to the literature and I found a couple of papers which are really trying to do this data capture and collection. What is our impact? So this paper looked at the energy consumption of radiology, energy and cost-saving opportunities for CT and MRI. What they asked was, how much energy do we consume and where could we potentially save? They investigated 3 CT scanners, 4 MRI scanners, and their associated cooling systems. They measured kilowatt-hour energy and integrated energy consumption with room usage. When was the patient being scanned? When was the scanner in idle state? And when was the room actually closed? And they had very interesting results. The yearly energy consumption for the CT and MRI scans that were evaluated accounted for 4% of the whole hospital electricity consumption. And this was equal to the consumption of 852 people in Switzerland. They found that the dedicated cooling systems accounted for 44% of all energy consumed. And in CT, 66% of the energy consumption was during the idle state, and in MRI, 33% of the energy consumption was during the system off state. And I've given some of the histograms demonstrating the energy usage for during the net scan, during the active, during an idle period, and during the off period. And we can see that there are substantial gains to be had despite not impacting on patient care. This was another study which I was very drawn to, the Green Fingerprint project. Here they looked at the consumption of PACS workstations. And they found that the power consumption of 32 PACS workstations was equivalent to the yearly carbon consumption of 12 households in Switzerland. And the pink area is the on state, the blue is standby, and the green is off. And we can see that the majority of time, the PACS stations were on the on state. However, they then modeled changing by reducing the time of standby from 4 hours to 1 hour and then switching off. And by modeling this, they found that they could save 45% of the original electricity consumption of our PACS machines. This is actually something that we can do now. We can do this as a community. We can actually go home and do this next week. Although there are software programs now that can help us with this. And we need to look at this, we need to measure our baseline consumption, and we need to see the impact of some changes that we can make. Another very important study looked at the environmental impact of interventional radiology over a 5-day period. This was more challenging because they looked at life cycle assessment. They recorded waste generated in the IR room, the quantity of disposable supplies and linens, the operating time of electrical equipment between 7 a.m. and 7 p.m., and they looked at the life cycle assessment for purchases, the plug loads for electrical hardware, data from the cooling units, and the estimated travel of staff and patients to come in for their interventional procedures. And they had standard procedures, drainages, venous access, CT-guided biopsies. These were the common ones. So let's look at where the carbon was generated. This was the greenhouse gases 5 days in interventional radiology. And I don't have a pointer, but here we have carbon dioxide emissions and against what's producing them. And we can look, first of all, at the lowest histogram is the gas anesthetics used. Then we have the lighting, the electricity for the non-imaging equipment, the linens, the waste disposal, staff commuting, and electricity for the imaging equipment, relatively low. But what was really incredible was to see that the production and transportation of the single-use supplies had a massive carbon impact. We need to plan carefully what we're going to use in each procedure. We need to be mindful when we're opening single-use kit, and we need to see where we can change potentially back to an old-fashioned system whereby we have reusable kit where appropriate. The other astounding thing was that 25% of the greenhouse gases generated by climate was generated by the climate control, the air conditioning and heating. And astoundingly, over 50% of this was generated at night and on the weekend when the room was not in use. We can change this now. We can make a difference now. We have a climate emergency. This is a very nice paper which gives us ideas as to what our departments can change again next week. This was a paper by a Canadian group looking at greening the radiology department, not a big mountain to climb. So here we have things that we as radiologists can do without huge governmental changes. We have a responsibility to make our departments environmentally friendly. Small changes across all our departments can make a big impact cumulatively. Auto shutdown of PACS, projectors and computers, motion-sensitive lights in our reading rooms, care with water usage, air conditioning and heating, contrast management. Departmental waste is something that we can address straight away. We can change to biodegradable cups. In one department in this Canadian paper, they found that 1,000 cups per day were being used for patients, and that really needs to be biodegradable. We can have separated waste for recycling, food, biodegradable, non-biodegradable waste. And we need, as I said, to have care and attention when we're planning procedures with single-use equipment. We need to identify areas where we can change to reusable equipment, and we need to think about the cost of laundry, single-use gowns versus washing. And this paper gives some simple steps. I really highly recommend it as a guidance for us to start changing our ways. Another thing that I noticed in January was that the French Society, they're really on top of this, and they published a white paper in January 2022 for Radiology et éco-responsabilité. And they have a broad authorship, including partners inside and outside radiology. And they identified 4 main themes: digital sobriety, as they call it, the lean ICT. Then they identified new tech, including heavy equipment, robotics, and connected objects, the life cycle assessment of these. They also have a group looking at contrast agents and another on waste management. So here they're really putting resources into looking at how we can make changes in our departments. The life cycle of a diagnostic process is what we really need to be measuring. But this is very, very challenging and difficult. How can we get started? We do need data. In our department, we've started off an environmental sustainability group led by Dr. Sarah Sheard, one of my radiology consultants. And we have a broad group with managers, we have radiographers, radiologists, and nursing staff. But we've decided we have to start simple. We're going to start with some sub-metering projects where we can put a little meter on a plug at a PAC station. We're going to start measuring baselines. We're going to start collecting simple data so that we can then see changes that we make and what impact these have. We can also do important things right now, which is about decision support. Is the test necessary? Are we doing the correct test the first time? Do we need contrast? We have vaccine passports now. Why not develop radiology passports nationally? We need to know if patients have had a scan somewhere else that we could use and avoid any repetition of work. We need digital sharing of images. We need to avoid repeat procedures because these generate a lot of cost in itself, the patient coming to the hospital and all the costs associated with that scan. Departments need to start measuring and evaluating their performance against environmental impact, as we do with clinical audit of diagnostic accuracy, waiting time, and turnaround times. And we need some investment. Certainly in the UK, the research funding is through the NIHR, and they are now doing funding rounds for net zero innovations in healthcare. So we need to step up and apply for these research grants. We need to design projects, apply for the grants, collaborating with environmental engineers. And we need to partner with industry. We are in this together. We need the industry partners to work with us. So, in conclusion, when we look forward, we know that our radiology domain has technological advances all the time. We move along at pace. But I think the department in 2030 is going to focus on more societal areas as well. We need to focus on patient care and strong communications. I think we're going to have a dashboard for patient experience. We need to look at the workforce developments as we change into adapting to AI, data integration, and we'll probably have a dashboard for patient training, staff well-being. But today we're talking about monitoring environmental impact. We need to act to reduce consumption, and I believe we need dashboards for emission and waste. So we need to change these radiology KPIs. We need societal KPIs alongside the financial and turnaround times. And this is what I hope to see in the future towards 2030. But as my kids say, that's Andrea's world, but I hope we're going to make it by 2030. Thank you.
Thank you so much, Professor Brady and Professor Rockwell, for the presentation. As was mentioned, so we are in this together, and we are happy to hear also an invitation of the industry, so I'm from Philips, to this discussion, and we invite the broader collaboration on the topic. Also, as mentioned, the topic is complex. At the same time, we need to team up and collaborate to make it simpler, yet impactful. Therefore, I would like to present to you some ideas how to team up to define metrics and methodologies to decarbonize imaging and make it also together achievable, sustainable, impactful, and easy to integrate into current radiology department. Full disclosure, so I'm an employee of Philips, of course. Brief recap. As Professor Rockwell mentioned, healthcare is responsible for about 8% of emissions in the United States. Globally, it is 4.4 global carbon dioxide emissions emitted from healthcare. That's when about half of the global population doesn't have actually access to radiology. Just think about that. We need to do something different here going forward. A part of it is also healthcare uses 10% of materials globally, of all the materials usage, which also includes hardware of the imaging department. Therefore, to decarbonize healthcare, we need to team up end to end. So we invite the collaboration across the value chain, obviously starting with the hospital radiology department, what's important, how we can, what will generate energy and to save energy. And then therefore suppliers, partners, regulators, collaboration with the governments, with the NGOs that also can step in and support the research, or the government that can help the regulatory framework to make certain changes. And to connect to patient experience, as was nicely mentioned in the previous presentation, and engage the staff. So when we look at the metrics, current metrics and indicators of sustainability, today the different health systems, hospitals, practices are applying quite diverse elements. NHS was the brilliant first national health system to announce the race to net zero. This is great, and it requires suppliers to commit to net zero. That's one angle, right? So, at the same time, European Union requires suppliers of medical equipment to offer green products. That's a different angle. That's a different metrics applied here. In our experience in Philips, we are receiving various also tender requirements, and then you have the colorful pie charts with different elements, ISO, waste management, substances, different reporting. So we would like to see how we can actually cluster, simplify it to something that each of us can understand and act upon. Key questions that we hear also from health system leaders on sustainability. So they are a bit diverse. The topic is new. It's a new field, new area, but especially from the young generation, from the young radiologists. So it's the topic that will not go away. So will not let it pass. And the most important questions, so the most relevant question is how exactly to understand my carbon footprint? How can I reduce my total carbon footprint, yet in the combination with the patient-centric care and other clinical and operational priorities? So we suggest to you maybe to start thinking alone, to think together about such framework. So this is a quick draft that we put here and invite for your feedback, and maybe we can co-create it together going forward. First of all, on the top of this chart is we need to do the baseline assessment and evaluate the maturity. Also, as Professor Rockwell mentioned, we need to measure. Okay, so how much do we emit in the radiology department? And then we recommend looking at three improvement levers. First of all, energy efficiency. of course, but also carbon neutral solutions. Solutions before they arrive to your department. So you need to actually be attentive whether they have been manufactured in a way that reduces carbon already. Second lever is the circularity. It's actually the material use. How can we keep it in the system and not let it then be thrown away, wasted to land or burned? But actually we need to keep that material, reuse, repurpose, and then apply it again. Third lever is a very important one, very close also to patient centricity. It is about optimized and clear care pathways that reduce carbon footprint as well. An important element of this at the bottom of the slide is engaging all the staff, monitoring continuous feedback loop as well. A little bit about each of the levers. On the first one, about the energy efficiency and carbon neutrality. Also building on the previous presentation, medical equipment uses a lot of energy of the hospital. But most of this energy used, it is during the idle state, when the equipment is not performing scans. So this is about usage behavior. This is also about awareness, and it's something that can be relatively easily implemented. The other element of this is that actually before the equipment arrives, look into manufacturing of the equipment and also application of the renewable energy, wind power, solar energy, and what happened actually before the equipment arrived to you. The middle picture here, it is about the delivery itself. In fact, switching from, for example, air shipment to the ocean shipment can significantly reduce the footprint as well. It means longer timeline, it means longer planning, but it's also puts it into perspective and thinking strategically. The last but not least is also the systems that can reduce actual amount of material used, and especially scarce materials like helium. So today technology allows us also to save significantly usage of helium and not necessarily replenish it. Circular solutions, that's also building on the previous point. So today we are using way more materials that the Earth can regenerate and can recover. Therefore, through product take-back, product life cycle extension, repair, refurbishment, remanufacturing, and also innovative business models, looking into equipment differently, because what we need is technology. We do not need everything that comes with it. We need a technology that it performs exactly and performs first time right. Here there's a picture of the study that we did together with the University of Exeter about the circular economy and circularity and its impact. Also circularity is supported by digital technology. Software, servers, and hardware is growing carbon dioxide footprint. So therefore, we need to think of the also move to a cloud or move to a green cloud, sustainable use of this software, and also even servicing this software so that people do not travel to do the installation, to do repair, also to take the equipment off of the usage, and that also provides a very good benefit of that. And then last but not least, lever, of course, optimized and clear care pathways. For example, delay diagnosis implies more carbon, or rescans as well. And interesting also in the first bucket, there are big financial costs that resulting from unnecessary, suboptimal and repeat imaging. For example, in the United States, it's about $10 billion. And that's where financial lens and also sustainability lens and the clinical lens come together. For example, smart diagnostic systems, connected workflow, they can help reduce environmental footprint as well. Example here is the spectral CT technology, that's technology of Philips, just as an example how it can do first-time right diagnosis and reduce in time to diagnosis, and also reduce repeat scans, for example, 25%. All right, then exciting part of sustainability, because I've been working in the field for quite a few years, but it's a very nice topic to talk to colleagues, to talk to staff about. It's an exciting, engaging area. And in fact, in several projects that we have done with hospitals in Europe, so we received the feedback that we need to engage more staff. The staff would like to be engaged, would like to be informed, they would like to see the dashboards, and they even suggest to take responsibility for sustainability implementation. Then how to act. To go fast, go alone. To go far, go together. We need to do both. To go fast, for example, perform self-assessment, identify improvement opportunities. Simple, measure, reduce, mitigate the rest, engage your colleagues, and repeat. So this is something that we recommend and perform in the quick self-assessment so that we can do tomorrow. To go far is teaming up together across the value chain, and that's where we are inviting the collaboration on sustainability methodology in the radiology department. Also with the public sector, NGO, we work in protecting green health and health without harm, for example, United Nations agencies. That's important. So we need to find solutions to shared environmental, social challenges, and no one has all the answers, but we call for collaboration, and here we can make it simple yet impactful and move in steady steps. Thank you so much for the opportunity.
Before we proceed to begin the panel discussion, I'd just like to remind the viewers online and those who are here in the audience live to please use the Slido function on the ESR Connect or the ECR 22 app to communicate with us. We would love to hear your input and your questions and comments, and we'll endeavour to pass those on to the panel and answer them as best we can. But while we're awaiting some input from the audience, I have a number of points I'd like to raise or questions I'd like to ask with the panel. Professor Sardinelli, can I start with you? One area I know you have a particular interest in is contrast usage, contrast recovery, and the impact of pollution from contrast usage in radiology departments. Do you want to tell us a little bit about that, please?
Yes, the overall topic is absolutely relevant, and to follow this line, we have to think about all things. For example, to pay attention to appropriateness of imaging, to reduce useless examination. But we have to think of the new things. And one of these new things is to think about, to quit, to transmit in the environment the contrast agent with the patients that freely have the urines that go to the water, to the environment. So what we are doing now, we start the enrollment of the study in the next week because we have the ethical authorization and the health authorities authorization, is to ask the patients to cooperate, to change their behavior and to gather the urines for at least 1 hour after the examination in the department and to give this urine to us that we collect, and we will examine what is the concentration of iodine and gadolinium. We work on both MRI and CT. And this is the first try to involve the patients in a project in which we recover the gadolinium and the iodine in the urines. What I foresee is that the cooperation will be high because there is a sensitivity of patients, there is a sensitivity of the public on this topic. What we could do is to stimulate a new behavior. And finally, what I think generally is one of the most important things in both the talks is we have to measure. We have to start to measure with score, with indicators that look as what is the situation, to have a starting point and to see what happened thereafter for energy consumption, for recovery of contrast agent and so on. Otherwise, we don't have any metrics for this. I think this is an important point.
Thank you. And Just to pick up on one of the points you made, Alessia talked about teamwork and getting everybody involved. I think the initiative that you're involved in has the particular angle of getting the patients to take some responsibility themselves and to be involved in the team. And I think this is very important.
This is important, and also a special, also in the authorization in the ethical committee, we obtained that the consensus can be practiced by the technicians and the nurses. Mm-hmm. So not something that is not covered by the physician or the radiologist necessarily, but the enrollment in this project can be directly managed by the technicians and the nurses. So it's a team project that work on this.
That's great, thank you. I want to turn to Dr. Pinto next and talk about COVID and how COVID has impacted on sustainability in radiology. I think we've all seen during the worst excesses of the pandemic, we've seen coffee shops move away from encouraging people to use reusable cups. We've seen the reintroduction of disposable coffee cups, the increase in waste from use of personal protective equipment and masks. Has COVID had an impact, a negative impact on efforts in radiology departments to make themselves more sustainable, do you think?
Well, I mean, I wouldn't, well, that's a difficult question probably, but I would think that actually in some parts it even has a positive impact maybe on radiology departments. I mean, during the worst times, like a number of people stayed home, worked from home. Those were in part people that had long commutes to work. So I think, I mean, overall, of course, the situation was very special. Some parts certainly increased overall waste production and everything. But I mean, just adding maybe to what Professor Sardanelli said, I mean, we have to look at the whole chain of things that happen around our department, and I think also the commute is probably part of that. So, I mean, the things can't probably be looked at individually, but need to look at it in a broader picture. And yeah, certainly waste was definitely a thing, but then again, other effects maybe counter that to some extent. If that's...
Yeah, I suppose this brings us to the point of how do we measure the entire life cycle carbon cost of much of the work we do. Of course, you raised the issue of people actually traveling to work. Does that have a negative impact on a department's output? And this brings me to the next question. I want to post this one to Professor Durkee, if I may. Should we be thinking more about delivering radiology services more closely to patients' homes than we do at present? We've all practiced in an era when there's been a greater concentration of resources in larger centres, in bigger academic hospitals, where the patients come to us. There are fewer of us than there are of patients. Should we be going to the patients to try and reduce the carbon impact of what we do?
I would say probably not. It depends on which kind of services. A simple ultrasound, yes, maybe. Chest X-rays or something like that, very simple, yes. But for complicated examinations, I think we need to gather competences, both technical, high-quality machines, and subspecialized radiologists in some places to act as a hub where patients have to go, I would say. But for me, the most important thing is to do the right examination at the right moment, at the right patient. That is, follow the guidelines. So we need the cooperation of the referring physicians and make them understand that if the hospital wants to become green, radiology wants to become green, the hospital has to become green. And to become green is better done if everybody does the right thing at that right moment. So, as it has been already addressed, repeated examinations or redundant examinations, which do not add anything to the diagnosis, are useless. And the second topic, I would say, everybody in the radiology department and in the hospital should think and act as if he or she were at home. Close the light when you get out of the room. Close your computer when you get out before going home at the evening. all these kind of things which can be done immediately, it is not too much consumption, but it is, if it is done by everybody.
Of course, I take your point that the right test at the right time is by far more important than where we deliver that test. But I think there must surely be scope for healthcare planners to consider whether simple plain radiography or simple ultrasound could perhaps be delivered more in satellite centres in a large city, for example, rather than bringing everybody to one centre. At least it's something that should enter the calculation of
It has to be calculated, but it depends on the level of complexity which is expected. The pre-test probability of difficult disease or difficult condition to be evaluated. Because in some cases, a general radiologist can do anything, but if there is something subspecialized that you need, at least, you can work and in teleconsultation. That means sending the images to be seen by a specialist. But it is some schizophrenic situation in which you want patient often asked to have everything close to their home, but they need also top quality service. It is not possible anyhow. I remember there were big troubles in closing a maternity, a place where women went to have birth in my city in the western part. But it was less than 400 births per year. And under such a level, it is almost impossible to guarantee high-quality birth, safety to both mother and child. So it was forced to be closed.
Yeah. I don't think any of us would argue on the safety point. Of course, you're absolutely correct in that. Andrea, you wanted to come in on that point.
I just wanted to come in about the what we might call imaging hubs. So certainly in the UK, around the world, everything shut down, and we have a very large backlog of imaging to get through. And at the same time, of course, I work in genitourinary type imaging, and prostates now, we're doing, prostates before biopsy. There's a lot of things now that really ramped up the volume, and we can't manage it within the existing structure of the hospital imaging departments. And so now we have these imaging hubs where we have MRI scanners, CT scanners, etc., that are close to like suburban areas, if you like, and the radiographers there are trained. We actually can check protocols remotely, and the scans come to us for reporting. They come to our own MDT. And so, for example, with the prostates, some men don't need to come in for a biopsy because the prostate MRI scan is satisfactory, and that we're actually measuring all the carbon reduction that results in, because we don't have patients coming in and out, etc. So I think I agree that some very highly complex things cannot be done peripherally, but I think there are some opportunities to do CT. There's quite a few, like staging, follow-up staging CT and things like that, which we do in these imaging hubs. Our main difficulty is that they put all these scanners everywhere, but we haven't increased the number of radiologists. So that's more of the challenge. But we have managed to develop these imaging hubs in the local areas, which I think will have quite a carbon impact. Hopefully.
Yeah, thank you. Please.
Only a very small comment about the issue of to introduce this concept when you project a new hospital. For example, we have to think about the example of nuclear medicine for the bathroom dedicated to patients. So the recovery of gadolinium and iodinated agents could be projected with specific bathrooms for the patients, with the example of radiation or radioactivity issues of nuclear medicine. So when we project a new hospital, all these concepts could be introduced in thinking about a new organization that, for example, saving energy and recovery, the waste, the package and so on, but in particular for the iodinated agents and the gadolinium, I think.
Yeah, that's a useful point. I think planning of hospitals historically has been more about the patient experience and delivery of service. an additional element undoubtedly in the future is going to have to be sustainability of how we deliver those services. And indeed the fuel price increase that we've all seen, I think, have focused a lot of governmental minds on this as well as personal minds. So I think this is an area that we will see action on. I hope we will. Alessia, may I ask you some rather technical questions in a sense? And please forgive me if they're outside of your remit, but I'm interested in knowing how we can define a product as green. What criteria can we use? Is today's CT greener than last year's because the carbon dioxide emission of its production and its use is less, or are there other elements we need to take into account?
Yeah, I think it's an excellent question. So ultimately, we would like to go to a metric that is one simple for all, for example, carbon emissions equivalent. Yeah, but on the practical stage right now, on the product level, and to make sure that it's comparable also across the industry. So, for example, in Philips, we are using eco-design principles. Eco-design principles, so there are specific several parameters. So versus previous generation comparable system, again, without going into usage, because it depends where it's installed, how it's used, and then carbon footprint changes. But without going there, so we measure energy efficiency, so it is significantly better than the previous one, packaging, circular requirements, and also other elements like, for example, harmful substances and materials and improvement of this. So several parameters that are comparable and something that you in the radiology would be able to compare across the industry. For this, they are supported by eco-passports, and then other industry members have this as well.
You spoke in your talk about repurposing old equipment and upgrading it rather than replacing it. Is there an economic incentive for manufacturers not to encourage that or not to develop that capability? And is there a conflict in some way in that?
Yes, absolutely, but it also depends on the understanding the impact, the necessity of this, and then it's possible to make it financially sustainable and attractive. For example, we are fully committed to this, as was mentioned that in the new hospital we can do all sustainable, but also in the old or in the current department, in the old equipment, that it's significant carbon footprint. We cannot just let it go to waste, significant footprint of materials. So we would like to harvest it, to take it back, and then see what can be used, reused, and then the next system built with those parts will be as good as new, same quality requirements apply, but we keep this material. And then if we do it significantly, so then it will be beneficial also financially for everyone, all the participants. Yeah.
Sorry to keep coming to you with the difficult technical questions in a sense, but one of the reasons CT scanners are left in idle mode as long as they are is that they take a long time to boot. And I think we've all experienced that with ultrasound machines over the last 10 or 15 years, the boot up time has substantially reduced. Therefore, it's much easier to walk into a room, switch it on, scan the patient, switch it off when you're finished than it used to be. Is there movement in boot up time for CT scanners? Is that getting faster? Do you see that as being something that the industry can help us with?
I think that we are interested actually to collaborate on this topic, because whether it's a switch off, switch on, or whether it's when it's not, so the energy consumption when there's no exam performed, maybe that one would be beneficial. So we are interested actually to collaborate to understand that better, because something has to be done. Yeah, fully agree. At the same time, there are other levers that we put. So energy consumption is one part, but then the workflow, then we are trying to think it broader so that it's more also actionable. Maybe workflow, or maybe materials part, something would be more impactful in this case, in CD. But absolutely we need to look into that, yeah. And I would need my engineering colleagues actually to explain that in details to have a full answer to your question.
Thank you.
Apologies for that.
Thank you. We've had some interesting input from the online and on-site attendees, and I'm going to read out one that's a little tricky and perhaps pass it to you, Andrea, for comment. You're good at these. Isn't it fair to say beside dozens of positive aspects, that face-to-face events like these are an easy carbon footprint problem to solve due to the travel of attendees and huge halls that aren't full. We've all experienced 2.5 years of not being able to meet face-to-face, and the delivery of education and continuing professional development has changed somewhat in the last couple of years to a more online format. Is there a justification for continuing to do what we're now doing this week and meeting in person?
I think it's a really important debate that we need to have as a scientific community. I know that recently we've had some face-to-face teaching sessions again, running courses and events such as this, where you can really feel the difference in terms of meeting people, networking, collaborating, meetings around the table where you're trying to make changes and improvements in our community. And I think there is a need for a certain amount of face-to-face collaboration and education. I do think that the pandemic gave us an insight into the opportunities we have to reduce travel where this is going to be, where this works. And we have a really successful online programs, e-learning programs that are really fantastic. And I think that is something that has changed the way we're going to go forward. In my own mind, I think the number of meetings probably needs to be reduced. Sometimes there seems to be some repetition, or the meetings are too frequent, or what have you. And I think to look at in the round, how can we actually really have beneficial face-to-face collaborative meetings, and then try to reduce the overall number and burden of meetings and courses, etc. To find a middle way, to find a hybrid way, maybe not the full electric way, I don't know. So maybe, because I personally, maybe I am old-fashioned, I do find it really enhances the teaching and learning experience when I have students with me, beside me. But I accept that this cannot be how we do everything going forward. We have to make a change, there's no doubt. I mean, I guess that's my perception. I don't know what others feel.
And I think the process of our even considering that and beginning to debate it has been vastly accelerated by the pandemic. And that may be one beneficial outcome from the pandemic. There haven't been too many others. Daniel, I want to turn to you as an informatics expert and ask you about what ways artificial intelligence can in some way help us to reduce our power consumption, reduce our waste, reduce our wasteful practices in radiology departments, or are there any in use right now?
Thank you for the question. Actually, I think that's a great question. I think there's two parts to this question. For one, I think there is a potential of AI, especially when we think about contrast media. There may be some ways to further reduce contrast media usage just by enhancing the images through AI, and I think that's probably very important. On the other hand, I think sure there may be some situations where AI can help, but again, we probably have to think about the broader picture. And of course, I'm an informatics friendly person, but I think with imaging as a whole, but also with AI in imaging, we need to think about what does it add to the patient, what patient's outcome. And I think much of what we see currently in AI is probably, of course it's nice to have, and there's some very valuable applications there, but then I think the development and installation, having things running and so on, the whole infrastructure requires a lot of energy as well, and that's certainly something that we need to think about. There may be situations where it outweighs, so the negative impact outweighs the positive, and there may be some where it's the other way around, for example, with contrast media reduction or something. But again, I mean, it's a very complex topic, and we need to look at it, I think, on a very large scale to really, be able to estimate where the benefits lie and where the actually challenges increase.
An unexpected debate that's been happening quite a bit in my country in the last year or two has been about the energy usage of data centers.
Yeah.
We have all gotten used to things being available to us everywhere via the cloud. We've all gotten used to using the internet for everything, but this requires data centers somewhere that are hugely, they're huge users of energy, and because of our climate, Ireland has attracted a lot of these centers. But they're now using a very large proportion of the energy output of our country. Are there lessons we can learn from that? Should we put all data centers in temperate countries that don't require a lot of air conditioning?
Well, good question. I mean, I just, before the session, I read something about the energy usage of these data centers. Unfortunately, I can't remember, but it was a considerable amount of greenhouse gas, obviously. Again, I think there may be good arguments why you should have a lot of smaller data centers, but then again, I could imagine that, you know, centralizing things has so much, produces synergy effects that you need less cooling for the same amount of data storage. Then, of course, you have the data transmission, which you need to think about as well. But again, maybe, I mean, it's just such a huge topic, and actually, I agree fully with what has been said. We need to measure things to really estimate what we can do and what we should do, actually, because without data, we can't inform our decisions.
Yeah, as you say, it's complex. I mean, one comment here I just want to read out that we received, and it refers back to Professor Rockall's comment about radiology passports and reducing unnecessary repeat imaging. The contributor wrote, "There is probably no need for a radiology passport. There is rather better digital connection required. I work in Australia, and I know that all doctors have access to the images a patient has received. No risk of unnecessary examinations and no printouts required." This is a very good point. If we have a good information exchange infrastructure, then yes, that will consume a certain amount of energy, but on the other hand, it will save patients unnecessary exposures and save unnecessary studies. And as you say, Daniel, ultimately the calculation is hugely complex. But nonetheless, this is a good thing to aim for. Professor Durkee, you wanted to come in?
I wanted to stress a little bit that, in my opinion, it is not the green radiology department which has to be taken into account, but it has to be taken into account the green healthcare system. So we are not in isolation. We are within a hospital and within a national health service. So these kind of things have to be discussed first at the hospital, at the regional or national authority level, then at the hospital level, and then in the radiology level. So we are starting bottom up. Maybe it has to be discussed also top down. I mean, we can success in such a, I would say, revolution maybe, only if there will be the work of the whole hospital around us.
And I think even casting the net a little bit wider, we also must have the consent and buy-in of the patients we serve, because for them it is to some extent a trade-off. Are they better served by our being slightly less green, or will they accept perhaps slightly different services to what they might have expected in the past in order to improve our environmental impact? Patients have to be involved in these conversations.
It is anyhow a complex system.
Yes.
And with every complex system, there are not easy solutions.
Yeah. Daniel?
Maybe if I just may add something to that, because I think that's very important. Actually, I liked the study from Basel a lot, where they analyzed that. I had the pleasure to meet the author in the German Congress, and what they actually found as well is that, of course, the newer generation of scanners, for example, in MRI, or, well, it was not the new generation, but 3 Tesla compared to 1.5 Tesla, there's a difference in greenhouse gas emissions, obviously. And it was interesting because they brought up that some patients would, well, traditionally they like to be examined with a newer, more fancy machine, 3 Tesla, and everything sounds better. But then again, there's a growing number of patients coming up that really have that in mind, like the environmental impact. And for those, maybe 1.5 Tesla is something they would prefer because they know that will use less energy. And actually, just to add on to what Professor Durkee said, I think we as radiologists, we also need to think about what is the right imaging at the right time, but also, do we always need the best imaging? I mean, it's a very difficult thing to weigh against each other, but sometimes 1.5 Tesla might be enough. Sometimes 46 slice CT might be enough. So, I mean, that's our responsibility as well. Of course, nicer pictures are always nice, but sometimes it's a good enough picture that does the job as well, just as well.
Yeah, I think that's a very important point. Francesca, you wanted to come in on that?
Only one notation about looking at the past to foresee the future, no? So when we pass from printed images on films to CD, the transition was relatively fast. We have a resistance from physicians that wanted the printed no more than 6 months.
Yeah.
But the transition from CD and printed report to all digital, I think is not so easy. Because patients ask frequently for CD with images and printed reports. So we are facing a world in which all is digital, but the transition to a completely digital transmission of data, images, and reports is not so easy. This is something on which we should work because neurologists or surgeons want the patient to bring them the CD with a printed report. So we have to manage this, I think.
And patient portals may be part of the answer to that, from the patient perspective at least, perhaps less so from the referrer's perspective. We're almost at the end of our time, so I just want to quickly go through the panel again and ask everybody in 1 or 2 sentences what ideas can they give. Can each of the panel members give one idea that we could implement now in our own radiology departments that could improve our sustainability without significant additional investment? So I might start with Andrea.
Well, what we're doing in our department, our first project, our first simple project is about PACS sleep time. So PACS wait time, downtime, sleep time, we just want to change that as quickly as possible because we have a lot of machines that are hot in the morning when nobody's been in the room, and we need to fix that straight away.
And that's just an adjustment in the software.
Yeah, we're going to first of all measure in all the 3 hospitals what we're doing at the moment, and we have a software package that can centralize the switching off and switching on or sleep time. So it's a centralized AI automated we're going to look at the usage. We're going to then say this is what we're now going to do, and there may be hot rooms that are kept on for emergencies. So that's our first big project. And we've got another CT life cycle assessment, but that's the one we're going to do first.
Thank you. And that's something I think we could probably all easily do. Alessia?
Our recommendation would be actually talk to the staff. Talk to the staff, share the sustainability idea and support about it, and ask them, hey, maybe we can do something quick, low-hanging fruit, like and select one area that they are eager to quantify, to measure. One area that could be potentially impactful, and to measure that, whether it's PACS or whether it's a replacement of equipment or whether it's energy consumption, for example.
So engage the people we work with to do this. Yeah, that's a good idea. Lorenzo?
Turn off your computer and shut the light when you go home in the evening.
Like we say to our children, switch the lights off when you leave the room.
Exactly.
I guess there's not much to add. I 100% agree with everything said. Turn off the computer, switch out the lights, and try to have awareness of the topic.
Maybe ride a bicycle to work. Francesco?
My view is that in the future we will face a lot this issue of environment protection. And I think that one special issue is to see as a complete team of the radiology department can work on this. So we have to work for a complete involvement of radiographers, nurses, radiologists, and patients. Only if we work as a team with the patients, we will face this.
Make this a collective responsibility. I'd like to thank the panel for their most insightful contributions and talks, and this has been a fascinating topic. Have no fear, you will hear more about sustainability in radiology. It is a growing area of concern. As I mentioned earlier, the fuel price increases have made us think even harder about it in the last 6 months. But that's not a bad thing, that we do consider it as part of our working lives. And I'd encourage all of you to think about this further. And thank you also for your contributions, both online and in person. And we look forward to seeing you at future sessions during this Congress. And please evaluate this session online in order to achieve your CPD points. Thank you very much.